Thank you very much, Rochelle. And welcome to everyone. It's my great pleasure to be joining you from the North Shore of Lake Superior in Thunder Bay. I wish I was there in Montreal with all of you, missing so much all of my colleagues and friends. It's my great pleasure to be introducing our first speaker today, Dr. TANIA DUMONT. She studied medical school at Sherbrooke University and then did residency in obs-gynae at the University of Ottawa, and then ped and adolescent gynecology at Sick Kids in Toronto. She's been practicing adult gynecology at the Ottawa Hospital and pediatric and adolescent gynecology at CHEO for the last 10 years. In 2012, she developed with Dr. Rob Klassen, the Young Woman with Bleeding Disorders Clinic at CHEO, and she's also the gynecologist who takes care of women with bleeding disorders at the Ottawa Hospital. She published in 2013 a mini review in the peer-reviewed journal Pediatric and Adolescent Gynecology, an article titled, "Can von Willebrand Disease be Investigated on Combined Hormonal Contraceptives?" This is her third CODEROUGE meeting. Welcome to Dr. TANIA DUMONT.
Thank you for that lovely introduction, Dr. Laferrière. I'm just seeing my slides in very small right now. I don't know if it's possible to for the AV team to put up the slides in big so I can actually see them. Okay, I know we had issues with slides yesterday as well, so I will try to get started with these tiny little slides that are on my screen, and hopefully someone from Solotech can help us out. So I would first like to begin by acknowledging that the land from which I'm presenting is the traditional unceded territory of the Algonquin and Anishinaabe people. In terms of disclosures, I have received an honorarium from Novo Nordisk Canada for participating in the Dutch Menarche program, which is something I will not be discussing in this presentation today. I hope that by the end of this presentation, you will all be able to describe and interpret the various objective measures of heavy menstrual bleeding, articulate to your patients on how to use the various tracking tools for heavy menstrual bleeding, and assess the impact of heavy menstrual bleeding on their patients' quality of life. So I think before we dive into all these objectives, we really need to make sure that we're using the same definition of heavy menstrual bleeding. So this definition came from the National Institute of Health and states that heavy menstrual bleeding should be defined as excessive menstrual blood loss, which interferes with the woman's physical, emotional, social, and material quality of life, and which can occur alone or in combination with other symptoms. Any intervention should aim to improve quality of life measures. So if there's one thing that I want you to withhold or remember from this talk is that menstrual bleeding is excessive when it's excessive to the woman that you are seeing in your office. Okay, we are really going to need to see this, this slide in big. Okay, I'm hoping that you guys can see this in a larger screen, but we want to make sure we're using the right terminology and definitions. So previously, we used to use terms like menorrhagia or menometrorrhagia or polymenorrhea, and I still get a lot of referrals for this. And when I get referrals, stating you're using these terms, I don't actually really know sometimes what the referring provider is asking me to treat or look into. And when I actually take the history for the patient, I get something totally different than what I expected to get from the referral. So the SOGC put out a reaffirmed guideline, I believe it was in 2017, talking about the different terminologies. And this is things that you want to actually make sure you're talking about with your patients and asking about. So you want to look at duration, you want to look at frequency, you want to look at the amount of bleeding. You also want to look at if there's unpredictable bleeding, and that can be what we call postcoital bleeding, so bleeding after intercourse, or intermenstrual bleeding, bleeding between periods. or is it just before or just after? And then there's also the unscheduled bleeding of women who are on hormonal contraceptives, and we often call this breakthrough bleeding. So FIGO, which is the Fédération Internationale de Gynécologie and Obstetrics, actually put out a really nice table that you can use with your patients when you're seeing them in the clinic to be able to define what their heavy menstrual bleeding is. So on this slide here, what is in white is what is actually normal, and what is in gray would be abnormal. So, sorry, I'm just going to have to pull up another copy of this slide because I cannot see it. Okay. So at the top would be frequency. So this will vary from, one paper to the next, but in general, anywhere from 21 to 24 up to 35 to 38 days is considered normal in terms of frequency. And in adolescents, especially in the first few years after menarche, so after the first period, we actually accept cycles up to 45 days because we know that it's normal for them to be anovulatory in their first few cycles. Then we want to talk about duration. So a period anywhere up to about 7 or 8 days is considered normal. Greater than that would be abnormal. And then we want to talk about regularity. So I have tons of both teens and adults that come see me, and I never know when my period is. It's completely irregular. But really, when I look at their menstrual calendar, if they have one, then I realize that it's actually very regular. And what's normal is a shortest to a longest of even up to 9 days. So it's normal to not be right on time, quote unquote, every month. We then want to look at the flow. So heavy, normal, and light. And, a little bit later on in the talk, we will look at how to characterize that. And then you don't want to define the intermenstrual bleeding, whether, if they're not having any, that's what we would expect. That would be normal. And then you can look at the different types of random bleeding, where it is in their phase, if they're not on any hormonal therapy. And if they're on hormonal therapy, then we would call that unscheduled bleeding on hormonal medication, or breakthrough bleeding is the sort of the common lingo that we use as gynecologists. So now let's look at our first objective, which was the objective measures of heavy menstrual bleeding. So out of the Journal of Pediatric and Adolescent Gynecology, they looked at 4 different measures. And basically what they were looking at is that the old definition of what we would call menorrhagia or heavy menstrual bleeding, which was traditionally defined as 80 cc's of blood loss per period, or about more than a third of a cup of blood loss per period. So we're going to talk about the PBack score. The other things you can look at are changing a pad or a tampon every hour, which can signal to you that your patient is having heavy menstrual bleeding, or if they're passing large clots of about 2.5 centimeters in diameter during their period. And then the other one we'll look at a little bit more in detail are low ferritin levels. So the PBack questionnaire, which we heard about yesterday, and definitely have some experts on the PBack, which is the pictorial blood assessment chart, basically something you want to give to your patient to fill out. And at the top, you can see the number of days. And here on this example, you can see this patient bleeds for 6 days, but it could be longer, and that would tell us they're having prolonged menstrual bleeding. And then in the vertical columns, they would fill out per day how much flow they're having, depending on how many pads or tampons they're using, how soaked they are, and if they're having clots or flooding. And then when they bring this back to you, then you need to do some math as the physician. And you can see sort of on the bottom right there how you would calculate. So, when pads or tampons are not very full, it's 1 point, mediumly is 5, and then really full or overflowing is 10. And then you can also see small clots, large clots. And when you tabulate that for every day that they're bleeding per period, if it's over 100, that would be considered heavy menstrual bleeding. So this is going to take us to our first live poll. So I would encourage everybody to vote here. I'm very curious to see what you guys are all doing in your own centers. I want to know, how are you using the PBack? So number 1, are you sending it out to patients before the time of first consultation? And if so, are they almost always bringing it back to you at the time of consult? Or are you sending it before the first consult, but they often don't actually bring it back to you, or they forget to bring it in? Or are you, for number 3, giving it out or discussing it at the time of consultation and that they almost bring it back to you at their follow-up visit? 4, you discuss it at first consultation, but unfortunately they often don't bring it back at their follow-up visit. And 5 is that you actually don't use the PBack questionnaire. So I'll invite you all to respond to this poll. And if you have any questions about the PBack or any comments, this would be a great time to put those in. And I'm just going to look at my second screen and see if we're getting some results coming in here. So I know, or I've been told that there's a little bit of a delay, so I'm not seeing anything come up yet. Dr. Laferrière, are you seeing anything on your end?
No, I'm not. I can't see anything with poll calculation. But I did see the poll and I did answer.
Great, thank you.
Yeah.
We'll maybe just give it another few seconds, but if I don't see the poll responses, I will move on so that we can complete the other objectives for this talk.
Let's carry on. Perhaps someone can get those scores for us for later on in the talk.
Perfect, thank you, I agree. All right, so let's talk about the pros and cons of the PBack score. So some of the pros is that it's actually validated in adult women, and a score of more than 100 will give you a sensitivity and a specificity of about 80% for determining heavy menstrual bleeding, so more than 80 cc's of blood loss per period. The downside is that it's often not immediately accessible to healthcare providers, and that is what I was really looking at seeing what's going on in your institutions, if that's actually the case. Its validity is debated by certain researchers, and there's a paucity of literature pertaining to adolescents, which is concerning to me. So yesterday we heard Dr. Valentino saying that only 4% of gynecologists are diagnosing bleeding disorders, and as a pediatric and adolescent gynecologist in a tertiary care center, I would hope that I'm diagnosing more than 4% with the tools that we have in place and that we are using. But a very recent systematic review about the PBack noted that it's likely best suited to the controlled and specific environments of clinical studies where clinical outcome parameters are defined, and that the current lack of standardization precludes widespread use of the PBack in primary care. So now let's look at ferritin of less than 30 micrograms per liter, which would be iron deficiency. And if you guys haven't seen it, I would encourage you all to visit the Hemophilia Society website, and there's some free and accessible videos, one of which is by Dr. Kamisa, a hematologist from the Ottawa Hospital. And on the next slide here, I just took a few captures from her video that are very important. And I'm just going to pull these up on my screen because I'm not seeing them on the presenter screen here. So I think what you want to pay attention to are really your symptoms of iron deficiency anemia. So reduced appetite, cold hands and feet, pica, fatigue, tiredness, difficulty keeping up with their peers when they're exercising. And then you want to think about the causes of iron deficiency anemia. So of course, as a gynecologist, I think of, acute blood loss, so a very sudden heavy menstrual bleed, or a chronic on acute blood loss. And then increased iron demands or reduced absorption. So yesterday we heard about, taking iron. You want to make sure you're not taking at the same time as dairy products or thyroid medications or PPIs, which can decrease absorption. And then if we look at epidemiological studies, they're talking about heavy uterine bleeding, which is the same thing as AUB. About 63% of patients with abnormal uterine bleeding experience iron deficiency or iron deficiency anemia. And of course, again, we should know what definitions are. So in an adult woman, it's less than 120 grams per liter of the hemoglobin and a ferritin of less than 30. And really our goals when we're managing our patients with heavy menstrual bleeding should be to prevent blood loss and replenish iron with a goal of a ferritin over 50. So now let's talk about tracking tools. So this was our second poll. So we'll get everybody to answer this one, and maybe we'll get some answers. If not, maybe at the end during question period if we have time. So which tracking tools are you most using in your office? A paper calendar, the Clue period tracker, the Me period flow assessment, another one? And if so, please put that in your comments. It would be great to discuss them, or no tracking. All right, so we'll keep moving on just for the interest of time here. So the good old paper calendar, which we use at CHIO, and this was before, all our teens had smartphones and were better with technology than we are actually now. But what I still love about this calendar is that you can see a full year's worth of periods if they've been tracking, right? So if you took January and you saw they bled from January 1st to 12th, and then again from 20th to 26th, and they filled it out with, a full black outline, then I could really say this, this teen or this adult is having frequent, irregular, prolonged, and heavy menstrual bleeding. And if I told you that or wrote that in my impression, it would give you a lot more information than if I wrote menometrorrhagia. So going back to those definitions that we saw from FIGO, really important that we all know what we're talking about and what we need to investigate. Because yes, bleeding disorders cause heavy menstrual bleeding, but so do anovulatory bleeding, and those need to be investigated and managed a different way. So knowing if the cycles are irregular or prolonged is really important. The app I like a lot is the Clue, the app period tracker. And the reason for that is you can see from the middle image, it's very similar to the paper calendar. You can really see the frequency, you can see how long they are, the amount of flow. And the other nice thing is that they can track other symptoms that they're having. So dysmenorrhea or menstrual migraines. The Canadian Hemophilia Society also put out an app called Me Period Flow Assessment. And basically this is the PBack on an app. So it does the math for you, which is really nice. The patients just have to fill it out according to how many pads, tampons, or clots they're having. And it will do the math, and they can bring that in for you. I would say the downside from it is that you don't actually see the frequency or the cycle length, the regularity or the irregularity or unscheduled bleeding, which is also important in your workup of heavy menstrual bleeding. So finally, let's wrap up with the impact of heavy menstrual bleeding on quality of life. So I would like to read this to you. Menstrual disorders are common indication for medical visits among women of reproductive age, and heavy menstrual bleeding affects up to 30% of women throughout their reproductive lifetime. These complaints may significantly affect quality of life, result in time off work, lead to surgical intervention, including hysterectomy, and ultimately have a significant impact on the healthcare system. So heavy menstrual bleeding is important. We should be discussing, and we should ask patients how it's affecting them. Some of the questions I ask my patients are, how much are they actually spending on sanitary products? What about having to buy more underwear or sheets or clothes because of flooding and large clots? And do they have drug coverage so that we know what we can actually prescribe to them? And if they can't afford it, they're not going to use it, and we won't be able to help them. And one of the nice comparisons that I like to make is, one of the things I use a lot as a gynecologist is the levornodressel intrauterine system, which is a really good device. And 40 to 50% of our patients stop having bleeding altogether with it, and the others have a good decrease in flow. But upfront, it's $400 to $500, which is a lot for patients. But when you compare it to how much they're spending on sanitary products, I have some patients spending $30, $40 a month on sanitary products. So if you multiply that by 12 periods a year, that's almost $350 per year. So, in the long run, they'll definitely be saving money, if they can decrease the amount of sanitary products they're using. And then I want to ask about absenteeism. So in adolescence, that's how often are you actually missing school because of your heavy periods? And if they are missing school, I always follow up with, what are you missing your fun activities? Because if they're missing school, it may just be they have an exam or they didn't do their homework and they're using their period as an excuse. But if they're also missing their fun activities, that really tells me how much these periods are having an impact on the quality of life. And in adults, I always inquire about, not going into work because of their heavy periods. And I would say during this time of virtual virtual work. A lot of patients will tell me, I'm not missing work because I can take an hour and go lie down and curl up with my hot water bottle. But if they were at work, they would have to actually come home potentially. So these are important questions. So in conclusion, heavy menstrual bleeding is really an important factor for women. We need to ask about it. So first of all, please ask about menstrual details and symptoms of anemia. Remember asking about cycle length and regularity, as well as duration and flow, and other symptoms associated with heavy menstrual bleeding like dysmenorrhea. Ask about fatigue and pica and cold feet and the other symptoms of anemia that we saw listed earlier from Dr. Camisa. Encourage your patients to track. I always tell them, if you track, you will help me help you. And I will be able to figure out, are you just bleeding heavily because of your bleeding disorder? Or is there something else underlying, like a hormonal cause or a local lesion in your uterus that we need to investigate and treat as well? And finally, ask about impact on quality of life. And this is what we just talked about. So the financial impacts, as well as the absenteeism and the impact on school outcomes, as well as work performance. So thank you. It's been a great honor to be here this morning. And I think we have a question period. Dr. Laferrière, I'll turn it back over to you.
Thank you, Dr. Dumont, for an excellent overview that was clear and highly practical. So very much appreciated by me. My next role is to look to the audience to provide us any questions. I do see that I have the answers to the second question up on my screen right now, and that was which tracking device was being used. Can you see that, Dr. Dumont, the results?
Yes, I can actually see the results now, which is great. So we see that about 20% use the paper calendar, 20% actually use that Clue period tracker calendar like I use as well. Currently, nobody is using the knee period flow assessment, and a majority, so over 40%, are using another app. So I don't know if we can see in the comments what people are using. So there's a comment from Natalie Thomas who's saying some girls have their own app, and that's great. And I think, I may not have pointed it out, but the tracking that they're going to use is the best method. Yes, it's there in my conclusion, is the one that they will actually use. So yes, if they're already using an app, go with that for sure. Absolutely, I agree.
I have a question for you. Now, in terms of your practice, your referrals must be largely coming from primary care providers. Is that correct?
Yes. So I get referrals from primary care providers, so family doctors, nurse practitioners. But we also get referrals from some of our colleagues. So I will get referrals, let's, for example, in my adult gynecology practice, I'll get referrals from hematologists who have diagnosed bleeding disorders and the patients who have heavy menstrual bleeding. And same at CHIO, sometimes I will have referrals from my colleagues in gynecology or even hematology that are actually referring to that combined clinic that I do with Dr. Clausen.
So in terms of education of primary care and our nurse practitioners who are really the intake, they're the front line meeting our women with, what kind of educational initiatives are there for them to be able to understand the new language definitions and some of these important tools?
Yeah, that's a really good question. I think, attending certain CMEs that are available, there's lots available to primary care providers. The SOGC puts out an annual meeting, but there's also local CME meetings that are available. And, we're always talking about periods and how to manage them. And same thing with the North American Society of Pediatric and Adolescent Gynecology. For those of you who are seeing younger women, is a great resource. They have handouts for patients as well on their website. So there's a lot of resources. The SOGC website, the NASPAG website, they all have handouts for patients and for providers as well.
So is there a kind of standard, in terms of primary care education, are you teaching at the University of Ottawa? Are you providing those sessions, or is someone doing that to make sure that we're educating our medical students and new residents so that we're actually propagating better care going forward?
Yeah, so I do, as a gynecologist, I am asked at the University of Ottawa to teach some of the CBL sessions for the med students, and definitely we talk about heavy menstrual bleeding and how to assess it in those sessions. I'm sure they also have some didactic teaching, at least I can speak for the University of Ottawa. And then I have been invited as well in the past to family medicine conferences in our area to present on various topics, including heavy menstrual bleeding. So yes, I mean, anytime we have the opportunity to disseminate this information is important. And I must say that, you know, if you're referring, one of the things I would ask is at least always do a CBC and a ferritin and include that with your referral. It's incredible the number of referrals we get for menorrhagia and menometrorrhagia, and we don't even have a hemoglobin or a ferritin. And having that value helps us triage it, right? If we get someone, you know, that has abnormal periods, but their hemoglobin's 140, they're not going to be triaged the same as a patient who has heavy menstrual bleeding, but is getting referred with a hemoglobin of 70. So those are really important things to include in your referral.
Do you manage the iron deficiency yourself?
So I'm very lucky that at TO I have a combined clinic. So most of the time I manage that with my colleagues. I will, in my adult practice, manage the iron deficiency on my own if I'm doing oral iron. So yesterday we had this great debate on oral versus IV. I'm definitely comfortable with the oral therapy, but typically would refer on, and same as our practice at CHIO, if I need to do IV iron, it does go through the hematology department at CHIO.
That's great. I think the debate yesterday was brilliant. A call out to my brilliant colleagues, and I agree that you know there's utility for both products, and we're very pleased with that. Now I do see that we have the responses to the question 1 quiz results that are up. Can you see those there?
Yes, I can see them. So I guess in summary, a majority, so about 70% are not using the PBack right now. And of those who are using it, nobody's sending it out ahead of time, which means that, you know, you're doing your first consult and you don't actually have that information at time of first consult. So people who are using it are discussing it, it looks like, at the first consult. And unfortunately, you know, half of those are not even getting it back. So I think that was, you know, when we looked at the pros and cons of the PBack, I think that's sort of the we're not getting it back. It's a lot of information that we're missing out on, or the patients are forgetting. I find one of the nice things with the virtual visits now is if their patients are at home, and, you know, I used to have a lot of patients in clinic, oh, I forgot it on my bedside table. Well, now they're home. So I just send them up to their bedroom, and, you know, if we're doing a video visit, just show it to me, or if not, sort of, okay, tell me you bled from when to when, and I can do the math at least and figure out what their cycle length is and regularity and all that. But again, like one of our colleagues pointed out, is, you know, you need to find something that the teen or the adult is actually going to use. And I think we need to find ways to have them bring that information at their first visit, because often what's happening at these first visits is we want to initiate investigations. Sometimes we want to initiate treatment right away if their hemoglobin is really quite low. And so the tracking after that is less helpful, because most of the time we're starting them on, you know, some kind of hormonal treatment, which will actually take over their natural cycle.
I'm glad you brought up the issue of virtual visits. I'm wondering about the impact of the pandemic on access to care for your services, or how that was in the early and now in the later stages of the pandemic.
Yeah, so I mean, I can only speak to what was done at CHIO and the Ottawa Hospital, but so let's just starting with CHIO. So initially we did have quite a slowdown until we decided we were converting pretty much everything to virtual, and that took a couple of weeks, but we got on board quite quickly, and we realized we could do a lot more by phone than we thought we could, and we got very quickly, we got comfortable prescribing combined hormonal contraceptives over the phone and having the patients check their blood pressure before their follow-up. You know, most of our teens don't have any risk factors, and so as per guidelines were coming out, you know, we were concordant with that. Then we got comfortable with, you know, putting in the levonorgestrel IUSs in the clinic and doing a phone follow-up and having the patients do their own strength check rather than seeing them back in clinic. So we've really adapted to different ways that we could do, virtual clinics, and our guidelines at CHEO are still to mandate as much as possible, about 50% virtual. And so I think with time, we're figuring out which patients we really need to see in person and what can be done over the phone. And very similarly in my adult practice at the Ottawa Hospital as well.
That is brilliant. And I have to confess, in true disclosure, that I do have secondary gain in asking you that question. And that is that living in a more remote community and looking after patients who live remotely, they don't have the same access to someone with your expertise. And so I'm hoping that going forward, one of the results of the pandemic will be a kind of distillation, kind of a clarity that it is possible to provide such care remotely, at least at intake, and then to sort of consider which select patients would need to travel to a remote community for further assessment. Wondering what you think about that idea.
I completely agree with you 100%. Over the pandemic, what we've noticed is, for our patients abroad, instead of having to come in, it's been great. The other population for us that has been really helpful is our patients with developmental disabilities and, single moms at home that have 3-4 kids, and trying to bring all the kids at the visit at the same time. It's so much easier to be doing it over the phone. So I think I have the same hopes and goals that, virtual visits are here to stay for the population that it's right for.
That's wonderful. And I look forward to each of us in our areas of specialty being able to, in a structured way, review that so that we can bring some further access in the future. And certainly I've seen it in my referral to other centers where there's been a lot more willingness to take on telehealth. And we have a large telehealth practice here in Northwestern Ontario. And so at the beginning of the pandemic, I thought, okay, well, we're good. But of course, the first week in March, the telehealth service was so oversubscribed that we, who were, super users, just kind of abandoned and went to the phone. So where things are balancing out now, and I think we've learned a lot. Now I'm just looking here to see if there are any additional questions before I monopolize all of your time. And I'm going to let you know as well that I am really hoping to be able to invite you to one of our educational events here in Thunder Bay. We have twice a year. We gather all of the primary care providers together to update them in certain areas. And I'm thinking an Ottawa hospital, heavy menstrual bleeding, iron replacement would be a brilliant educational contribution to my community in particular.
It would be my pleasure.
That's wonderful. So I don't know that I see other comments. Do you have any final thoughts to inspire us with? Although I have to say today has really been outstanding, and I want to thank you so very much.
My pleasure. And honestly, it's great being here. I listened to the day yesterday. We have some amazing speakers, and I see the next panel that's coming up right now, and it's an honor to be speaking with all of you today and those who presented yesterday. So thank you.
Thank you.